All right, well, good afternoon. I'm going to speak to you guys a little bit here today about some knee pain and I wouldn't say this is an all-inclusive talk, but I'd try and hit some highlights on kind of the knee, kind of why it hurts, what we can do about it, and try and help you live the lives that you want to be living. So this is kind of my objective today. We're going to talk a little bit about the knee function, kind of how it works. We're going to talk about reasons for knee pain, basic symptoms, treatment options, I think is where we're going to spend kind of most of our time. And then at the end, I'll leave it open for questions, and hopefully we should have plenty of time to kind of review some questions and kind of talk about whatever you guys would like to talk about. So kind of first things, kind of how your knee works. So it's the largest joint in our body. It's typically referred to as a hinge joint because it does flex and extend, but it is a little more complicated than that because it also kind of rotates. It's made up primarily, as you can see here, of the femur, the patella, and then kind of the proximal tibia or the shin bone. And then in between, kind of on each side here, we have a meniscus that can also be a significant source of pain, as well as cartilage that kind of covers our joints. So I don't know if I can get this to play. Let's see. Sure. Is that better? Yeah. Okay. So this is kind of just a little diagram of the knee as it moves back and forth. You can kind of see that there is a little bit of a different rotation. And when we start talking about kind of knee replacements, this is kind of what we try and recreate, the kind of natural movement of the knee. So reasons for pain. This is not an exhaustive list by any means. There are multiple other reasons, but these are kind of some of the more common things that I see in my clinic. Osteoarthritis is one of the most common. We see it quite a bit as people age, as well as it's associated with the wear and tear arthritis. The next most common thing is meniscal tear, and it can be related to arthritic progression. Not always the reason for pain, but it can be kind of a confounder. Ligament tear, sprains, strains, more common with acute injuries. Baker's cyst, kind of related to mostly intra-articular pathology or pathology going on in the knee. So it kind of goes back to, for the first point, osteoarthritis. And then muscle imbalance, tendinitis, various different tendinitises can kind of lead to muscle imbalance, changing your gait, changing the way you walk, and causing further problems and issues. So it's estimated that at least 70 million people in the U.S. have some form of arthritis. These aren't the only kinds, but the most common kind is osteoarthritis, which is a wear and tear arthritis. Degenerative condition, it doesn't get any better, and it potentially can get worse. It's an opposed kind of to rheumatoid arthritis, which is kind of a completely separate issue. It's an autoimmune disease. Again, doesn't really have anything to do with age or use, but again, it does not get better either. So kind of what is osteoarthritis and kind of some of the basics of that. So on all of our joints, and actually in our entire body, our joints are covered in cartilage. So cartilage, what it does is actually provides a cushion, provides a smooth gliding surface for the joints to kind of move smoothly and be able to walk and do the things that we like to do. As the knee gets diseased, the cartilage starts to wear, and that's essentially what arthritis is a wearing of the cartilage that can lead to further problems. So just kind of diagrammatically, you can kind of see this is the normal cartilage kind of right here and right here. This is fluid in the knee, which we do have a normal amount of synovial fluid in the knee, and this is a relatively healthy knee. And so as we start to go down further progression of osteoarthritis, you can kind of see the cartilage starts to break down, as is in evidence here of kind of the wavy surface here. Our synovial fluid becomes less. Pieces of bone and cartilage can actually break off, float around in the joint, and we can get bone spurs. As things continue to get worse, eventually most of that cartilage goes away as it's worn away. And so you have what I'm sure a lot of people have heard about, a bone-on-bone arthritis. At that point, you know, that's something where we talk about a knee replacement. So causes of osteoarthritis. We know, at least in our current state in the U.S., that we don't have an exact cause of osteoarthritis. We think it's mostly multifactorial. We know that weight and diabetes have a big portion to do with it, as well as genetics, as well as injuries, as well as you know, kind of other factors associated with knee pathology. So symptoms of osteoarthritis. This is just pretty basic. You know, typically it's chronic knee pain. You can see some knee stiffness, swelling, inflammation of the affected knee, difficulty with everyday activities. May need assisted devices, canes, walkers, wheelchairs, kind of all of those things. And I'll tell you kind of what I see a lot is clinically it may be asymptomatic until there's a small injury that kind of makes the problem worse, that it can be kind of clinically silent for quite a while. So going on to kind of treatment pathway, so we have kind of three different areas that we talk about for treatment. The first one being kind of non-pharmacologic interventions, pharmacologic, and then surgical interventions. These are kind of the three basic categories that we typically see, and we'll do most, if not all of them, before we start talking about any type of surgery. So again, this is a big problem. Obesity is a big problem in the United States at this point. It's a disease where essentially fat is accumulated to the extent that health is impaired. It's, again, multifactorial. It's not an easy problem to fix, otherwise we probably would have fixed it by now. It's lifelong, it can be progressive, it can be potentially life-threatening as well as it's costly. This is kind of what we talk about. You may have heard the term body mass index. That's what we talk about when we talk about, essentially it's not about how much people weigh, but kind of their mass index with their height and then their weight together. And we know that people that have a body mass index over 40 or 6 times are more likely to have complications when we start talking about surgery. So it's something that we really look at. It's something that's I think in the medical literature a lot, and it's getting bigger with, unfortunately, with insurers. So why do we have this problem? Why is obesity such a challenge, and why is weight loss such a challenge? And what are the problems with it? As you can see here, there's multiple different areas that obesity affects. Kind of one of the big ones are cirrhosis of the liver, obstructive sleep apnea, which is pretty common, depression, hypertension, metabolic syndrome. It does put you at increased risk for cancer, and osteoarthritis. So it's not just a problem with your joints. It's a problem with kind of everything in between. So again, as we kind of discussed briefly, weight loss isn't easy. There are multiple reasons why. As you can see, it kind of provides a whole cycle here that all kind of are interrelated and interconnected, that make weight loss, and it makes it understandable as to why we have a problem in the U.S. population today. Again, So, you know, we can see that there are more common things associated with obesity: hopelessness, depression, anxiety. I thought this was an interesting statistic. 50%, you'll spend 50% more on healthcare and 80% more on prescription drugs. And it's more likely related that typically people that are obese have more problems, more issues, and so that's why they need more pills, more healthcare, kind of things like that. So, so this is kind of a slide that shows us why it's so difficult to lose weight, and a lot of it's got to do with kind of a complex interplay of hormones. We typically have what we call a set point that kind of regulates your weight, and your body doesn't like to go below that set point. So we start dieting. Then your body says, nope, that's not right. We need to get back up to our set point. And so you can kind of see this fluctuation, and that's why a lot of times too we see with dieting that people have rebound and gain more weight afterwards, is because that set point kind of wants to keep going higher. It worked. It worked very well for a while, but in this day and age, it becomes more of a challenge for us. So another intervention that we talk about besides weight loss, that's kind of one of the big ones, but also physical therapy. And this is, I think, one of a cornerstone of trying to get people back to a functional level. You know, we kind of retrain the gait mechanics, strengthen muscles that have become weak, strengthen muscles that have not been used appropriately, and to try and strengthen some of the muscles around the knee, the hip, and the core. And it can decrease pain and increase your physical function, and it's a very effective intervention. I think it really helps a lot of people. We have a lot of studies and data that show that physical therapy can really help you get back to doing what you want to be doing for the most part. So now on to pharmacologic interventions, and this is kind of where we start with the over-the-counter pain relievers. And typically we have kind of two broad categories. One on my right here, you'll see that it's the over-the-counter NSAIDs, or non-steroidal anti-inflammatories. These consist of ibuprofen, naproxen, aspirin, meloxicam, Mobic, diclofenac, Voltaren. You may have heard of some of these. You may be on some of these. These work very well for inflammation. They work well for pain. They are a very good medication for that. On the other side is Tylenol or acetaminophen, and it too works well for pain. And it can relieve kind of minor aches, pains, and they have different mechanisms of action, so they can be taken at the same time without interfering too much. You know, the right over-the-counter pain reliever really kind of depends on a lot of different things. It depends on other medications you're taking. It depends on, you know, what medical conditions you have. It depends on age. It depends on kind of a whole host of things that, again, that, like I said, are based on kind of you the patient. And so, you know, we really like to make sure that we get you on the right one, or the one that's best for you, again, depending on conditions and other medical issues. So next kind of intervention after we talk about non-steroidal anti-inflammatories as well as Tylenol, another modality we have would be a knee injection. And the injection that we're talking about first is hyaluronic acid. And so what that is it's a chemical that's naturally found in our synovial fluid, or in the fluid of your knee. As we age, as we start to get some wear and tear, this chemical is not found in the same quantity that we see in a normal joint. So hyaluronic acid, injecting it into the knee in a concentrated form, can actually act as a lubricant and a shock absorber, and it can actually help decrease pain in an arthritic knee. So again, it is FDA approved. There are multiple different formulations. I think the last I counted was around 30. So yeah, I just put a couple up here that I tend to use. And you know, they may give some pain relief in an arthritic knee for up to 6 months. I've seen it go even longer. I actually have had a few patients that come back and see me every year, and they just want just a hyaluronic acid injection. That's it. So,
May I ask something like
sure.
Is this anything kind of like a steroid?
Is this anything like a steroid? Is your question? No, it's not. I haven't gotten there yet, but we'll kind of get down. But no, this isn't a steroid injection. And so you can see here on the bottom too, there's also 3 or 4 injection series. There's 1 injection series. It's kind of all over the map. So again, you know, what these are used for is to try and thicken up the synovial fluid. Kind of helps cartilage that's not doing so well. It decreases the inflammation in the knee, and it helps to kind of decrease some of the enzymes that tend to break down cartilage. Again, for up to 6 months or more. This is what she was referring to as a corticosteroid injection. This is another injectable modality for knee pain. It can provide very good pain relief. You know, corticosteroid essentially is kind of the ultimate anti-inflammatory, and results for that can be up to 3 to 6 months as well, sometimes longer, sometimes less. This is kind of a bias of my own practice. I don't really like to perform them more than 2 to 3 times a year. There are some risks with corticosteroid injections, of which we don't really see with the hyaluronic acid. So that's why I kind of limit those a little bit. So on to surgical interventions. What can we do after most, if not all, of these other interventions have failed? Kind of where do we go from there? So there are multiple surgical procedures that can be performed for knee arthritis and just knee pain in general. Kind of the most invasive to least invasive, or least invasive to most invasive. The first one here is kind of arthroscopic debridement, and that involves a scope and a camera, some small incisions, typically. This is a benefit in some arthritic knees, but not everybody is a candidate for it, as there's kind of specific criteria that we use for that. The other thing we talk about is osteotomy, which means we're kind of cutting this bone here. And that's really useful in people that have kind of one compartment arthritis or another. And so we can kind of unload this compartment. If this compartment's affected, we can unload it and kind of load some more of the weight bearing over here, and that tends to have good 5, 10, 15-year results. It is not a long-term solution. It tends to wear out at about 10 to 15 years. That's kind of a useful thing for some of my younger patients, 40s, 50s, 60s, that don't really want a knee replacement yet and want something done. And then the last thing we talk about for treatment of arthritis is knee replacement. This is kind of what it looks like, and it's a very effective treatment for knee arthritis. So kind of continuing on our journey here, we start talking about partial versus total knee replacement. And so as you can kind of see here, this is a partial knee replacement. This is a total or full knee replacement. So there are many different factors that are associated with, you know, doing one or the other. The extent of arthritis, the type of arthritis, if you're too bow-legged or knock-kneed, it becomes more difficult, as well as a flexion contracture and weight or BMI also have roles to play in this. And I will tell you kind of, I think partial knees are really good. I will tell you the most common reason for failure of them is progression of arthritis to the other side. So it's one of the problems. So as you can see, kind of over here, we kind of see the red dots. So we're kind of more just an isolated inside part of the knee or medial compartment. And so partial knee is a good solution for them. You can see this side of the joint, or it's hard to see probably, but is relatively unaffected and doesn't really have a lot of disease in it. So this was probably a very good solution for this person. It's kind of here on the bottom, you can see they did a nice red coloring. I assume that means pain or ouchies. And you can see kind of the best result for them is a total knee replacement. So what does partial and total knee replacement? Kind of does the same thing. We remove the damaged area of the knee. So in this side, it's kind of the inside of the knee. And replace it with metal and plastic implants that help relieve pain and restore kind of more natural movement. So some of the benefits, potential advantages of partial knee replacement, I think really what I see most is potential for faster recovery. I think it's a little bit smaller surgery, it's a little bit less invasive, and I think we keep more ligaments intact, and so I think it tends to be a little bit easier to recover from. But again, not everybody's a candidate for it. So go on to kind of down the spectrum, and we're talking about full kind of knee replacement at this point. It helps relieve pain, restore mobility, and overall is probably one of the most successful surgeries we do in orthopedic surgery besides a hip replacement. You know, if you look at the medical literature, 90 to 95% of people are happy with their hip or knee. As you can see, the numbers are drastically increasing. 2012, 660,000. By 2030, we project 1.28 million in the US alone. So this is a problem that's going to keep getting bigger and keep being a problem. So knee replacement essentially is a surgical procedure that replaces diseased joint surfaces with implants that are made of metal. This is cobalt chrome, plastic, which this is polyethylene, and then cobalt chrome on the other side as well. And these provide a solid bearing surface with the plastic in the middle to provide for wear characteristics. So how do we do a total knee replacement? How does it work? Essentially, we know that the diseased areas of the knee are essentially right here. So we kind of make some small cuts here on the femur. We make another small cut on the tibia, and then we make a few more cuts on the femur that are kind of on the side there, so they're hard to point out. And then we essentially recap the tibia and the femur with the cobalt chrome that we saw, cobalt chrome here, and then that polyethylene in the middle. We also will put a small piece of plastic behind the patella as well. This is kind of a spectrum of disease and kind of what we see on x-ray. So this is a nice healthy knee. You can see we've got kind of good joint spaces here and here. Don't see really any osteophytes. Don't really see much of anything. It looks really good. I'm sure it's what all your guys' knee looks like. I don't think it's what my knees look like. You can see here's a diseased knee. You can see here we've kind of lost the complete joint space, both on the inside and the outside of this knee. Decreased joint space. We have quite a few osteophytes or bony overgrowths kind of all over the knee. This knee is starting to fall into a little bit of bow-leggedness. So in my opinion, in my practice, the best cure for that, or the best solution to that, is a total knee replacement. So fixed bearing knees are the knees that we typically use in the US. It's the most widely used knee, and that means that this bearing platform, this polyethylene here, doesn't pivot. There are some companies that make that pivot knee, but it really hasn't been shown to increase survival, increase patient satisfaction, increase really anything except for cost. So I think these are some of the questions that I'm sure kind of ask yourself on a daily basis. And really, I think these are the questions that need to be asked as far as when you're, you know, when we're talking about a knee replacement or just even talking about joint pain in and of itself. You know, how bad is the pain on a daily basis? Has the pain and loss of function affected your quality of life? Are you able to do the things that you want to be doing? Or do you wake up and think, man, I can, you know, go out to the mailbox and back, and that's all I can do today. So I'll keep that off to the afternoon because that's all I can do. You know, do you have problems sleeping, performing basic functions, going up and down stairs, driving, walking? You know, are any of these, you know, things that are problematic for you? You know, and I think if they are, then you know, I think you maybe need to talk to somebody about it. You know, I would tell you that osteoarthritis is a degenerative procedure. It doesn't get better on its own, and it may get worse. So I just put a little bit in here about kind of rehab and recovery after a total knee replacement or even a partial knee replacement or really any kind of just recovery after surgery, really. It's a little bit different kind of depending on, you know, what surgery you had done or what, but still some basic principles, you know. So you can bend the knee the same day. Sometimes you'll need to be in the hospital, sometimes you won't. If you do have a knee replacement, rehabilitation will begin within a few hours after surgery, and it can last up to 3 months. I think everybody's a little bit different. I think everybody kind of improves at a different rate, and so sometimes it's a little bit longer, sometimes it's a little bit less. The goals of the rehab are to kind of improve muscle strength, increase the movement in your knee, and get you to return to most of the normal activities that you want to be doing. That's a definite goal to do this procedure. Sure.
Does normal activity include sports?
What sports would you be referring to?
Skiing?
Yes, yes. So normal activity, in my opinion, includes skiing. It does not include contact football. It does not include basketball, except for shooting. It does not include high impact activities that involve jumping is really what we worry about. But skiing is typically okay.
How about hiking and backpacking?
I'm sorry?
Hiking and backpacking?
Hiking and backpacking, yes. Yes, you can get back to hiking and backpacking. Yes. Just some basics here. You know, we've kind of come a long ways as far as wound care after surgery. I use a dressing that's a proprietary dressing. It's impregnated with silver. Bacteria hate silver, and so they're kind of like werewolves, I guess. You can shower with the dressing on, and you can remove the dressing at 7 days. And then kind of just aftercare of this, you know, there are plenty of things that we can do to kind of make this knee start hopefully getting better. And a lot of it has to do with kind of getting enough rest, you know, eating nutritious foods, you know, kind of taking it easy for a while, but still be walking and doing things and getting back to activity. But I guess don't overdo it is what I would say. You know, so for patients who requiring surgery, total joint is a vast improvement in pain relief and functional activity in most patients. So, you know, again, you know, going back to kind of the same thing we kind of talked about, just kind of figuring out where your pain level is, assessing your pain on a daily basis, and you know, kind of try and be honest about this. Like, how much really does it hurt you? You know, is it painful to walk more than a block? Does it interfere with your sleep? You know, are the pain medications not doing anything for you? Is it limiting? I think this is a big one that I kind of see is it limiting your participation activities and family vacations and kind of things that you want to be doing? You know, and I think that's a big thing on this. You know, and this is kind of just a basic chart on looking at your mobility. Like, can you do these things? Do these things cause you pain? Do these, you know, just few activities? Is this where your problem's at? And if the answer is yes, then maybe we should see somebody. In summary, this is osteoarthritis is the leading cause of knee pain. It's degenerative. It does not get better by itself. Early diagnosis and treatment, I would say, are important. I don't know necessarily for total knee replacement it's important. And like I said, the 90-95% patient satisfaction rate. So that's me. If you would like to copy this down, I'll leave this up here for a few minutes, and I guess now I'll open it up for questions. Whoever would like, well, I'll see you first here. Go ahead.
So I'm curious about your comments on regenerative stem cell therapy. I received this in the mail, and I have no idea if it would benefit.
Sure. So his question's about regenerative stem cell therapy. So yeah, I'm sure people have all seen this. It's something new that's coming out. It's the next greatest thing. I would tell you at this point, results are promising. I will also tell you insurance does not cover it at this point. I will tell you the last I heard, I had a patient that told me she was thinking about it, and she told me it was $5,000 a shot. So yeah, I think it's a great concept. I think it's getting better, but I don't think we're there yet, and I wouldn't tell any of my patients to go fork over that kind of money for therapy that we just aren't sure of yet. Mm-hmm. Go ahead, right here.
You may warn everybody not to get both knees done at once, because I think you know who Armin Loizo is, who just had both knees done.
I
and he
don't.
was determined to do it, and everybody kept telling him, don't do it.
Yeah.
But he did, and he said, I wished I hadn't done it.
Yeah, so her comments about doing both knees at the same time, it's not something I typically do in my practice. There are some people that do. If you look at the medical studies, the safety profile is good. It's a viable thing, but there are some people, yeah, that don't understand what they're getting into.
That was a lot of pain.
Yeah, there can be. Yeah, right here in front.
What about prolotherapy without the stem cell injection?
So her question's about prolotherapy. I will tell you, I don't know a lot about it. I was kind of looking into it a little bit. I would say that I don't know enough about it to say yes or no. And I would say that is because when you look at the prolotherapy and you look at the data for that, everything seems to be kind of different as far as what they inject. So it's not a standard protocol. It's not like corticosteroid, like we put steroid in your knee. There's various different agents that they use to hopefully increase inflammation to then try and heal something, which in the knee typically isn't what you need to begin with. There's too much inflammation to begin with, and so that's part of the issue. So I don't, like I said, I don't have a ton of research on it, but I wouldn't endorse my patients to go get prolotherapy unless they really wanted to. If they want to, I don't know that it hurts you, but I don't know that it helps. Over here.
How can you tell if your knee pain comes from your back or not? I have a friend who had total knee replacement. He spent about a year in the gym doing all the rehab and all. Then he had a hip replacement, and he got up and all the pain was gone in his knee after all that time. And also I heard that back problems can affect your knees too.
So her question's about kind of separating back pain, knee pain, hip pain. And yeah, that's a good question. I mean, that's what we attempt to do. We do know that there's some referred pain from the hip that can go to the knee. And so unfortunately, I guess I would say that that is a known cause, and we try and avoid that by either getting a hip exam or hip X-ray beforehand. As far as the back typically causes different symptoms than what we see with kind of knee arthritis or hip arthritis.
What type of symptoms?
There are a lot of different symptoms. One of the most common that comes to mind is shooting pain down the back of the legs. That typically is not from the knee or hip. That typically is from a radiculopathy. So pressure on the sciatic nerve. Yes, right here. Sure. So her question is, what causes Baker's cysts, and are they likely to come back? So the best data that we have is that Baker's cysts are a response essentially to intra-articular pathology or arthritis, meniscal tear, cartilage damage, kind of all of those things that go on inside the knee. Essentially what happens is the lining of the knee, called the synovium, starts producing more fluid. That fluid needs a place for it to go. And so it goes out kind of the weakest part of the knee, and that's typically in the back of the knee, and that's typically where you get a Baker's cyst. So in and of themselves, they don't typically go away because there is an intra-articular problem. With a knee replacement or some other treatment, they can go away. But addressing the Baker's cyst isn't the issue. Typically, it's an issue inside the knee. Yeah, right here. So her question is, knee wraps, knee braces, what's my opinion? I think they can be beneficial in some people. I don't think that they are a great long-term solution. I think for acute injuries, they can be very beneficial. So I use them on a select basis. I won't tell them, and like I said, I won't say all my patients need them, but there are some that benefit from them. Yeah, over here.
I was wondering how long you would expect a full joint replacement to last.
Sure. So his question is about how long a full joint replacement will last. The best data that we have now, we're starting actually to get our registry studies out in the U.S. at this point, and what we have is about 15 to 20 years is what I would tell on average. Of course, some less, some more. And that kind of goes back to kind of talking to people about waiting and kind of trying these other things. We know that the younger we put them in, the faster they're going to wear them out. And so that's the reason behind that. It's metal and plastic. It doesn't remodel like bone. It has a finite life cycle. Hold on, I'm going to go right here first.
How much damage can be done to the upper and lower bone above and below the knee, where you can still do a knee replacement?
Sure. His question is how much damage can be done to kind of the femur and the tibia before we can not do a knee replacement or do a knee replacement, I guess, is what your question is. So I would say that answer is, I haven't seen many cases that becomes a problem. There are different implants. We have a lot of different options to be able to take care of difficult problems like that.
The lower part can be down several inches down below the knee?
Yes, yes, yeah.
Or a splinter to break type thing?
Are you asking what kind of implant do we use, or I'm sorry?
No, can you cut that bone off down 6 to 7 inches, and then can that lower part of the replacement?
We can. We can. We don't like to do that. We would rather leave the bone where it's at. Bone.
But if it was damaged, how?
It depends on how damaged it was. I can't answer that question specifically, but it really depends on how much damage there is. Yeah, right here.
I was wondering, you were saying something about you use chromium on the top,
Mm-hmm. Mm-hmm.
metal on the bottom.
Mm-hmm.
Now, does this cause a metal-on-metal situation like I had with my hip?
Sure. Her question is about metal-on-metal sensitivity or kind of metal-on-metal with the hip, and the answer is no. The metal-on-metal, it used to be a bearing surface that we used for the hip. Because of its wear properties, it was actually really great. Problem is, as you experienced, some people, actually quite a few people, had problems with the wear properties of the metal-on-metal. You get too much metal, and so it's the fact that your hip was bearing metal on metal. In a total knee replacement, there's cobalt chrome, but then there's a polyethylene or a plastic piece in between, and then the cobalt chrome. So you don't actually get the metal on metal wearing that you saw with the metal on metal hips.
Metals on metal will eventually work out of your system, go out of your system.
That's what we hope. I haven't seen any long-term data on that, but that's what we think.
Mine is that my metals were like at 5 something and at 7, and they were ready to go in and revamp. But I took some NAC, and my levels came down to 1 and 2. So I don't know. He said it could be because I took the NAC, or because metal on metal thing was over, and it kind of wore off.
Sure, it could be. It could also be the wear-in rate. We know that there was a wear-in rate that can be a little bit higher, increase your metal ions in the blood, and if that kind of goes over and stabilizes, that could also be another reason for it.
That's what.
Sure, right here.
Having said a knee replacement is 15 to 20-year longevity, at which point do you consider a person too old to have another one,
Like another primary or a revision?
if it was needed?
If it was needed? Primary? That's a good question. I don't know. I don't know. I won't, I'm not going to put an age on it. It's going to be an activity level. So if if I have a patient that comes in and, sits in a wheelchair all day and doesn't move, doesn't walk, and they tell me that they need a knee replacement, to me that doesn't make a ton of sense. But for somebody who's active and moves around and wants to do more things and things like that, I don't know that I would put an age on it. Really, I think it becomes more activity level and health. I think it's really the bottom line.
Well, my brother-in-law was 88, and he was like, done.
Sure, right here.
Cortisone shots, how long or how many can you get?
You mean in a lifetime, or like how long are you talking?
I've been doing them 6 years.
Sure. Yeah, I don't know. What I tend to find most in my patients is there's kind of a law of diminishing returns, and meaning that the second, third, and fourth shots don't work near as long as the first one. But if they are working for you and you're happy with where it's at, I'd say however long you would like. Again, I don't have any good data to support one way or the other. Sure, right here.
If you have neuropathy in your legs, how are you able to rebuild the muscles or not?
No, we are not able to rebuild the muscles. This question was if he has neuropathy in his legs, are we able to rebuild the muscles? No, we are not. We can only kind of rebuild the joint because that's a solid place, or a solid place, a platform of weight bearing. The muscles are what need to work to kind of move that joint. And if the muscles are weak or not moving, I won't tell you that a knee replacement will help that. Sure.
Manufacturer, I've done a little looking into different manufacturers of these.
Uh-huh.
Is there a particular manufacturer that exceeds the market, is a good product? Do you have any opinion?
Sure. My opinion is that there are a lot of good companies out there. I think if you stick with the big four that I kind of think kind of rule the joint world, and that's DePuy, Stryker, Smith Nephew, and Biomet, then I think you'll have a good implant with a good track record.
Thank you.
Yeah, back in the back.
You didn't mention anything about complications of the operation. I see some with the same complications 5 or 4 years after the operation. Also, what is better, is cemented, artificial fuse, or non-cemented? And what is your opinion on stem cells and treatment?
Sure. So that's kind of an involved question. So, what was your first part? Oh, complications. Yeah, I didn't go into any complications. That could be a whole separate hour talk, and it could actually go on for quite a lot longer. So yes, there are complications. There are complications with every surgery we do, and we know that. And there are some really bad complications with knee replacements. So yes, that is a part of it. It's not all sunshine and rainbows. What was your second question? Cemented and uncemented, yes. I think that's a kind of evolving technology that's kind of continuing to gain some traction. Right now, the gold standard is a cemented knee. I think that as we get our U.S. joint registry up and coming, I think we'll see that there are going to be some specific indications for a non-cemented knee. But right now, kind of our big indications are good bone stock, low BMI, no previous knee surgery. Those are the big three that I think about doing a non-cemented. I tell you, the problem is we don't have the longevity studies on non-cemented knees at this point. The longest study I've seen is 10 years, which they show promising results. I mean, I think they had like a 93 or 95% survival rate at 10 years, but we don't have the long-term studies that we do with a cemented knee. And then as far as stem cells, it kind of goes back to a similar question that was asked earlier. I wouldn't, at this point, I think they're a promising technology. I think there are some great things that are coming out with it. I don't think we're there yet to recommend them to my patients for everyday use.
Can you usually replace a total knee replacement? What problems would you have in doing a second replacement?
So your question's about revision, is that what you're asking about? Yeah, it's a pretty complicated issue. I don't think there's a simple answer to it, but yes, the answer is yes, we can and we do. And it really is kind of very individualized based on whatever your knee looks like and kind of things like that. It's not, I can't give you a straightforward answer at this point. Yeah, right here.
If your weight is low and you do physical therapy, you do your exercises, can you put off the deterioration of the knee if you have that osteoarthritis?
I'm sorry, what was the last part I didn't hear?
Osteoarthritis,
Mhm.
can you put off the progression of it if your weight is low and you eat right?
Sure. So her question is, if you're healthy, your weight's low, you exercise, you do some therapy, can you put off the deterioration of osteoarthritis? And yeah, I think it is. I think that's why we see, such good results with interventions of physical therapies. I think we get people active again, and I think it does slow it. It won't stop it. It won't stop it, I will tell you that. But yeah, I think it can slow it. And we know that kind of arthritis or osteoarthritis is a stepwise progression anyways. It kind of goes, kind of normal for a while, kind of gets bad, and then kind of levels off. So it's not just a kind of downhill progression. So yeah, I think those all can work to benefit and to help. Yeah, back there.
Kind of goes with that. What about myofascial trigger point, massage therapy?
So her question is myofascial release, trigger point injections, are they preventative? I don't think they're preventative. I think they help on the same level as physical therapy. I don't think they prevent anything, but I think they do help with just kind of pain, dealing with pain is what I think they help. Do I need to use this or is this?